morning, everyone. Big crowd. Glad to see it, and welcome to everybody who's watching online. As she said, I'm Dr. Whitney. I'm a Parkinson's and movement disorder specialist. I am one of a group of 5 all the way up in Fairfax, Virginia, so good to be down in the real South. And we see patients from all over Virginia, Maryland, DC, West Virginia for management of Parkinson's and other movement disorders. So I'm here to talk primarily about what we refer to as non-motor symptoms with Parkinson's. Everyone knows Parkinson's as a motor disease primarily, especially people who've never had Parkinson's or don't know someone who does. People know the tremor, they know the stiffness and slowness and walking problems and balance problems. But as Dr. De Leon talked about in her lecture a few minutes ago, Parkinson's is just as much a non-motor disease. People deal with lots of things that you can't always see. Problems with sleep, problems with bowel habits, problems with all sorts of other things like that. And I wanted to especially highlight the mental health, sort of mood, cognitive parts of Parkinson's that often go under-recognized and under-treated because of that. Don't have my slides. So here's what we're going to talk about this morning. We're going to talk about 2 main topics. I divided up sort of into mood symptoms and then cognitive symptoms. And sprinkled throughout, we're going to talk about how we deal with those things. These are both with medications, of course. Unfortunately, a lot of what we do with Parkinson's is taking pills, but also things we can do that aren't medications, things that people can do on their own or in the community that can be just as important in managing these kinds of problems. So when we talk about mood symptoms, we're primarily going to be talking about apathy and depression and anxiety. When we talk about cognitive symptoms, that's going to be dementia, hallucinations, and something called Pseudobulbar affect that we'll talk about a little bit later. And then, like I said, sprinkled throughout, we'll be talking about treatments. So the first thing to recognize is that these problems are very common. As I said, we think about Parkinson's as being primarily a movement problem, but mental health problems with Parkinson's are also extremely common. It's important to remember that even in the general population, even in people who don't have Parkinson's, many people deal with things like depression, anxiety, and these are even more common in Parkinson's because of the brain chemistry changes that happen with the disease. So again, we think about Parkinson's as being primarily a dopamine problem. If you know one thing about the brain chemistry of Parkinson's is that people with Parkinson's are dopamine deficient, but it doesn't just affect dopamine. It also affects serotonin. It also affects other brain chemicals that are important for mood and movement. And so these kinds of problems are more common in people who have Parkinson's than in people who don't. I put some statistics there. Depression's estimated to occur in about half of people with Parkinson's at some point in their disease. That doesn't mean that these people will be depressed for the entire time that they have Parkinson's, but at some point through their journey with this disease, depression can be an issue. And then anxiety and apathy are a little bit less common, but still almost half of people. And same thing, those can be things that are a prominent issue for people. They can be something that's relatively mild and manageable, but it's important to know about and it's important to recognize because if we don't know it's a problem, we can't fix it. So before we get into what we can do about these problems, I want to make sure we're all on the same page about what they are. Because again, if we don't recognize someone has an issue, we don't know we need to fix it, let alone how to fix it. So some of this is a little bit technical, but I think it's useful in talking about this, how these things manifest, how you might know if you have depression or anxiety. And so I thought the simplest way just to go through that was to basically talk about the sort of medical criteria for how we make these diagnoses, because most of it is just a discussion of symptoms. What people might experience in their day-to-day life that would be manifestations of, we'll start with depression. So the perhaps most obvious symptom of depression, the most common, is people feel depressed. They feel sad, they feel down, they feel blue, they feel low. Everybody uses different terms to describe this, but basically they're not as happy as they used to. They're not as joyful as they used to be. Things aren't as fun as they used to be. That is the most classic symptom of depression. Most people who have depression have at least some degree of that. But the other main symptom is something that we call anhedonia, which is essentially an inability to get joy from things the way you used to. So with a lot of people, that will manifest as their old hobbies that they used to love just aren't fun anymore. You have a whole set of model trains in the basement that you never touch. These kinds of things where people used to love things, used to enjoy life, and those same things that they used to like just don't do it anymore. And then there are these sort of secondary symptoms that some people may have, some people may not. And what's challenging with these is that a lot of these are just symptoms of Parkinson's anyway. So some of them are associated with depression specifically. Some of them feelings of guilt, feeling of worthlessness, feeling like you're a burden. That is common with Parkinson's. Feelings of, thoughts of death or suicide, thankfully is not a common Parkinson's symptom, but can be with depression. But some of these things like changes in appetite, and that can go either way. Some people can have a bigger appetite and gain weight. Some people will have no appetite and lose weight. Same problems with sleep. People can sleep much less or sleep all the time. And then, like I said, some of these are hard to tell whether it's depression or not. The third one on the list especially there, slowing down of thought or movement. Everyone in the room who has Parkinson's has that to some degree, whether they have depression or not. But these are important things to keep an eye out for because, like I said, a lot of people, especially with relatively mild depression or anxiety, don't recognize that that's what it is, don't recognize that it's a problem. This is just a picture of a scale that we use sometimes to screen for depression. This is called the PHQ-9, the Patient Health Questionnaire, and it's 9 because it's 9 questions. But it's essentially questions screening for those different symptoms of depression, basically asking people, do you have these problems, and if so, how often? And we don't always use these. A lot of the time we just talk about these problems in a regular conversation. But it's nice to have these tools that we can use to make sure we're not missing something that could be fixed. So depression specifically in Parkinson's, thankfully it's usually relatively mild or moderate. MDD, major depressive disorder, that's where people meet all those criteria we just talked about. That's relatively uncommon, but can happen in 10 to 20% of people with Parkinson's. But most people have some mild depression, people who have it, have some mild depression that we can generally manage. As I said before, some of the symptoms of depression can be hard to differentiate from just Parkinson's symptoms, and so it can be difficult to really tell unless there is an obvious low mood component. And people always want to know if their depression is related to their Parkinson's or not. It's a good question, but it's impossible to answer. There's no test we can do to say you have depression because you have Parkinson's or you don't. Thankfully, for the most part, it doesn't matter from a practical standpoint. The treatments are the same, whether it's related to Parkinson's or not, with one exception that we'll talk about in a little bit. But like I said, it's always something that's important to think about, important to kind of ask yourself those kinds of questions, because if it is a problem, we can fix it. So the next movement problem we'll talk about is anxiety. This, like I said, is a little bit less common than depression, but still very common, again, in the general population, but especially in people who have Parkinson's. And anxiety is essentially a tendency to worry and a tendency to be nervous about everything, to be anxious about everything. People describes themselves as a worrier. They're always concerned that something's going to go wrong. In order for this to be considered, again, generalized anxiety disorder is the official diagnosis, it needs to be something that's relatively frequent, not just anxious about one specific thing, but anxious about many things. And it can't be a thing that comes and goes in a brief period of time. It has to be something that sticks around, again, to officially meet criteria for what we call generalized anxiety. Some of the other symptoms that can come along with anxiety, these ones are a little bit different than depression, although there is some overlap. Again, there can be some feeling of restlessness, feeling kind of on edge all the time, amped up all the time, getting easily fatigued. The third one there, difficulty concentrating, is extremely common. Oftentimes when people have trouble finding words, trouble focusing on things, that can just be Parkinson's, but sometimes that can be an anxiety problem. Some muscle tension can be an issue, especially in the neck and the shoulders. And then anxiety can definitely cause problems with sleep. When people feel like they can't get to sleep because they can't shut their mind off. They lay down and they have so many thoughts going through their head that they can't relax. Oftentimes that's a manifestation of anxiety rather than a true sleep problem. And again, it's one we can fix if we know it's there. So again, anxiety specifically with Parkinson's, sometimes can be generalized anxiety disorder, what we were just talking about there, but oftentimes it is more specific, what we call social phobias, so anxiety about going out in public, anxiety about eating in a restaurant because you spill food, anxiety about specific things like that. And as I said, it can interfere with sleep. And I said before with depression that in general the treatment is the same whether it's related to Parkinson's or not, but with both of these, depression or anxiety, they can occur as what we refer to as an off symptom. So when your levodopa, whether it's regular carbidopa levodopa, Rytary, whatever is getting toward the end of the dose, starting to wear off before it's time for the next one, sometimes one of the things that can happen in addition to tremor and slowness coming out is people can get anxious because of that. And if that's the case, if that is clearly the pattern of when people feel most anxious, the answer there is not an anxiety medication, it's to fix the Parkinson's medicine. And the third major mood symptom we'll talk about is apathy. So this one's a little bit harder to define than the others. It doesn't have any formal criteria. So I thought I'd include this quote that actually one of my colleagues found years ago by Jack Kerouac, who said, "I don't know, I don't care, and it doesn't make any difference." And that is generally how we think about apathy, as sort of a lack of motivation, a lack of interest in doing things. This can sometimes come along with depression. Like I said, loss of getting pleasure from things that people used to enjoy is similar to apathy in some ways, but it can definitely occur as a problem on its own that has nothing to do with depression. So many people have some apathy, but their mood is fine, and that's how we distinguish them. Apathy related to depression is going to have some sadness, some low mood associated with it, where with pure apathy, people don't feel sad, they feel nothing. And this can be a big problem. It limits people from doing what they want to do, not because they necessarily consciously don't want to, but because oftentimes it doesn't cross their mind. I ask people, how much do you exercise? And they say, well, I can't find time, but they're sitting in front of their TV for 7 hours a day, and they just never get up to do it. And so apathy can be tough to treat. That's one mood problem where medications are not that helpful, unfortunately. And so because of that, we talk about a lot of non-medication strategies to try to manage it. The one that I tend to find the most useful is rather than each day trying to find the time, trying to find the motivation to do something, let's use exercise as an example, I find it useful to have people just build it into their schedule. Make a regular routine, pick a time, it doesn't matter, 10 a.m. every day, that's when I exercise. That way you're not sitting there trying to decide, trying to find the motivation to get up. That's your schedule, that's your routine, and keep yourself to it. Set alarms, make calendars, whatever it takes to kind of keep yourself on track and keep yourself accountable to get the things done that you need to do. I find it helpful both because of apathy and because a lot of people have some other cognitive issues that we'll talk about later. Breaking big tasks into smaller ones can be really helpful. It can be overwhelming to say, I'm going to go down and clean the basement. It can be much easier to say, I'm going to take care of these 3 boxes. And then once I'm done with those 3, I'll move on to the next 3. And with these, therapy can be helpful. We'll talk about therapy in general for mood in a minute, but therapy can be very helpful in kind of learning these tools and learning how to implement them in a way that's useful in your day-to-day life. And as I said before, medication's often not that helpful, but oftentimes we try. Sometimes antidepressant medications can be helpful for giving people a little bit of a boost. And so it's often worth a shot, although for apathy specifically, when there's not any depression with it, the effects from medications are often disappointing. So just a brief word on medication, especially for depression and anxiety. We always hate to say add another pill to your pill box, but they can be very helpful. First-line treatment for both of these problems is similar, which is good because a lot of people don't have one or the other, depression or anxiety. A lot of people have both. So the traditional medications that we use are what are called SSRIs or SNRIs. These are medications that basically preserve either serotonin or norepinephrine in the brain in the same way that some of our Parkinson's medications preserve dopamine. And there are a whole host of these medications without any real clear evidence that one is better than another. There are some studies that suggest that certain ones are more useful, but then there are other studies that contradict that. So really a lot of it is based on kind of what have people tried before, what is the ease of taking these medications, and some of them can be helpful for other problems. Like a few in the picture there, mirtazapine and trazodone in the bottom row, those medications taken at night can be really helpful for sleep. So if people have anxiety and insomnia, we might choose one of those medicines. There are a few of them there, the duloxetine in the middle on the top, venlafaxine in the bottom right. Those can be helpful for pain. So if people have neuropathic pain or tingling, we may choose one of those medications. So oftentimes we can get a few benefits out of one and kind of treat the whole patient rather than just treating one problem. The last thing, like I said, that if anxiety or depression is an off symptom, Parkinson's medications can help. There's also some evidence that the dopamine agonist medications, those are pramipexole, rotigotine, and ropinirole, that maybe those are helpful for mood just on their own, even when it's not an off symptom. But primarily our medications are the kind of antidepressant medicines we'd use in someone who didn't have Parkinson's. As I said, there's also plenty we can do that's not medication. So things like counseling or therapy can be very helpful, and it's important to keep in mind that if you meet a therapist and you don't like them, that's not the time to give up, that's the time to find a new therapist. Exercise can be very helpful. As a couple people have said already this morning, exercise is critically important for Parkinson's, but it's also very helpful for mood. People find that their depression gets better, their anxiety gets better when they're more active. Again, it's an endorphin release in the brain. All these neurochemicals are related to each other, and exercise definitely helps with mood. And then other things like, some people find emotional support animals helpful, some people find support groups helpful. There are all sorts of things other than medications we can do, although it's often not one or the other, it's often a little bit of both. And then for anxiety specifically, oftentimes breathing exercises can be helpful, muscle relaxation exercises, meditation, all these kinds of things that are easy to incorporate in your day-to-day life. These are not necessarily things you need to go to a therapist for or to a class for. Get on YouTube and search breathing exercises for anxiety, and there's plenty out there that you can do from the comfort of your own home. So like I said, reducing these things is not just about doing one thing. It's not just about taking a medication, although often that helps. It's about living a good life, all the kind of things that you would do for Parkinson's anyway, that are also helpful for mood. And as I said before, it's not medication or these other things. Often it's a little bit of both. So with that, we'll move on to talk about the cognitive symptoms a little bit. And I want to start with what we refer to generally as psychosis, but specifically hallucinations and delusions. And I find that people get these terms mixed up all the time. So again, I wanted to make sure we're all on the same page about what we're talking about. And so just to go through a few definitions, hallucinations, first off, are seeing something, hearing something, feeling something that's not really there. So the picture on the slide there is a little bit of an exaggeration, but that's a living room full of cats. I hope that whoever owns that living room does not own that many cats, but this is what it can be. With Parkinson's, just like many of the movement problems are characterized by things being very small, handwriting is small, movements are small. Oftentimes the hallucinations are of small things. I don't know why it's always cats, but it's always cats. Sometimes it's small children, not always. I have, this always stuck with me, a patient who saw a construction crew just kind of loitering in their house. They weren't doing anything, they weren't building something, they were just kind of there. Or kids sitting around the kitchen table. But the point is that these are things that people just see when there's not actually anything there. Illusions are sort of similar. They're sort of a version of hallucinations. But what we think about that as being is there is something there, but you see it as something else. So again, sometimes it's cats. Sometimes a pillow on the couch looks like a cat curled up. Sometimes a coat hanging on the coat rack looks like a person standing in the corner. So there is something there, but your brain, your mind is kind of misinterpreting what it is. And then delusions are a little bit different, and those are not sort of a sensory thing. People don't see anything or hear anything. They just strongly believe something that's not true. Unfortunately, some of these are kind of sad. So common delusions are people feeling that their spouse is cheating on them, that their children or their caregivers are stealing, that somebody's out to get them. But they're a version of the same thing where I kind of describe it to the patients as your mind is playing tricks on you, your disease is playing tricks on you, and this is something that we need to get under control. These, again, are fairly common. As I said, with the mood problems, these are not necessarily something that people deal with all the time for the entire time they have Parkinson's, but up to 50% of people will deal with these at some point. And there's a whole range. Sometimes a hallucination can be seeing a shadow out of the corner of your eye, you turn, there's nothing there, and that's that. But sometimes it can be more bothersome, more significant, and cause significant impacts in people's lives. Part of the reason this is so common is because these problems are partially a symptom of the disease, partially just part of Parkinson's, but also a common side effect with a lot of our medicines. That's what Dr. De Leon was talking about earlier with her combination of medications. That was what gave her some psychosis, and so oftentimes fixing the medication that caused it is just as useful as adding a medication to treat it. Pseudobulbar affect I mentioned briefly earlier. This is something that's very common in a number of neurologic diseases, not just Parkinson's. And what this is basically is an emotional dysregulation. So people cry more easily than they used to, laugh more easily than they used to, get angry more easily than they used to. Sometimes it is something that's appropriate to the situation. You get a old military veteran who hasn't cried in 30 years and now sad movies make him tear up every time. But sometimes it's completely unrelated to what's going on. There was an old song, probably from the 90s. There was a line, "I'm the kind of guy who laughs at a funeral." It's that person. And these oftentimes, again, are relatively mild, not bothersome, but can be a big deal for people. They can cause a lot of social anxiety, a lot of embarrassment. People don't want to go to events because people look at them funny. And again, it's something that if we recognize it, we can treat it. It's important to recognize it for what it is. And a lot of people with the sort of crying version of pseudobulbar affect, it often gets misinterpreted as depression. And it's important to recognize that because the treatments are different. For both of these problems, for the hallucinations, delusions related to Parkinson's, and for pseudobulbar affect, we have medications for them. With these ones, the sort of non-medication therapy kind of stuff is usually not that helpful, unfortunately, or at least less helpful. With these, really, medications are the name of the game. Like I said, with hallucinations or delusions, sometimes it is a side effect itself, and so fixing whatever's causing it can help. But when it's not, this medication, pimavanserin or Nuplazid, is a relatively newish medication that is specifically for hallucinations, delusions related to Parkinson's disease. There were treatments before that, don't get me wrong, but the old medications for these problems, what we call antipsychotics, they work perfectly well, but they work partially by blocking dopamine signals in the brain. And again, the big problem with Parkinson's, from a movement side at least, is that people already don't have enough dopamine, and so blocking dopamine further was very prone to causing side effects. This medication works on serotonin instead, and so it doesn't have that same risk, and so it's generally well tolerated. Thing to keep in mind is that it takes a while. It usually takes several weeks, up to a month or a month and a half to take effect. So oftentimes we'll use one of those older medicines sort of as a bridge to get people until their Nuplazid starts working. The medication on the bottom there, Nuedexta, is one for pseudobulbar affect. Can be extremely effective. I don't know how often it completely solves the problem, but as you can see there, up to 80% or so reduction in episodes, and that's a big thing for people. Kind of getting them more confident and getting them out in the world more without having to worry that they're going to laugh when it's not appropriate to do so. And so moving on to the kind of last main topic, I wanted to talk about cognitive symptoms a little bit. And the first thing to recognize is that most people with Parkinson's have some degree of cognitive changes. Maybe not right at the beginning, but at some point. But it's also important to recognize that most people with Parkinson's do not develop dementia. Some do. Different studies will give you different numbers. It's probably around 30, maybe 40%. But most people deal with milder cognitive changes, and these are things, again, Dr. De Leon touched on a little bit with her own experience, but things like trouble with multitasking, trouble with problem solving, trouble with mental math, what we generally refer to as executive function. And with a lot of thinking things, whether it's those things or even just what feels like memory, trouble recalling a word, it's not that you can't do these things, but that it's slow, that it takes twice as long as it used to. You know, just as everything else with Parkinson's, movement-wise is slow, thinking can be slow too. Usually this is not an early symptom with Parkinson's. Usually, especially the dementia, develops later on. And if people have early cognitive symptoms along with their movement symptoms, usually we think about a different diagnosis, something like Lewy body dementia, which can have a lot of the similar symptoms, but rather than having movement symptoms for a long time and then dementia later, it's usually both around the same time early on. Again, clarifying some terms, people get these mixed up all the time. Dementia is a general umbrella term for cognitive symptoms that affect function. So problems with thinking, problems with memory that limit your ability to do things for yourself. You used to be able to handle your medications, but now you're making so many mistakes that someone else had to help. Used to be able to drive, and not because of a motor problem, but because you were getting lost, you've had to give that up. Those are where we classify someone as having dementia, and that can be from many different causes. So Parkinson's is one cause of dementia. Most common, of course, is Alzheimer's disease, but there are many others, and some people have multiple causes. Some people have Alzheimer's disease and some vascular dementia, or something like that. I'm going to move a little bit fast through these since we're running short on time, but again, Alzheimer's and Parkinson's are two different things. People sometimes question, is my Parkinson's going to turn into Alzheimer's? The answer is no. They're different on a brain cell level. Like we said, Parkinson's affects dopamine, affects a structure called the substantia nigra, where movement comes from. But when those changes in the brain that start in the substantia nigra spread to other parts of the brain, that's when we can have some cognitive symptoms. Like I said, Lewy body dementia is sort of similar to Parkinson's in some ways. It has a lot of the same movement problems, but has more prominent cognitive symptoms early on. It goes by different names depending on who you ask. I prefer the term Lewy body dementia, but some people call it dementia with Lewy bodies, diffuse Lewy body disease, Lewy body being the name of the structural problem that's happening in the neurons. And like I said, Parkinson's dementia, Lewy body dementia generally, is very common, not among all people with Parkinson's, but it's the second most common cause of dementia after Alzheimer's disease. Like I said, true Lewy body dementia causes cognitive changes early on, although when people get dementia related to Parkinson's disease, a lot of the symptoms are similar, they just come later. Hallucinations are common with this, unfortunately. Parkinsonism, the kind of movement problems that people with Parkinson's have, happen in Lewy body dementia too. And then the other thing that's important to mention is that people with Lewy body dementia, or even dementia related to Parkinson's, can be very sensitive to any changes in their dopamine system. So sometimes dopamine medications, classic Cinemet, your dopamine agonists, will trigger hallucinations more in these people. And so sometimes we'll have to scale back the Parkinson's medications because they're just causing too many cognitive side effects. And these are the people where really those old anti-hallucination medications can cause problems, very sensitive to the side effects of those medicines. Again, we do have medications to help with these things. These are the main four that we have in terms of treatments for cognitive symptoms, whether they're from Parkinson's or Alzheimer's or anything else. The first category there are usually our first line. We'll start with one of those three. They all work essentially the same way. They all come as pills, and then the top two, donepezil, just recently they released a patch version of that. That is a patch that you change once a week. And then rivastigmine also comes as a skin patch that's a once a day. These are used, like I said, for cognitive symptoms, whether related to Parkinson's or from anything else. And then there's a second category of medications. I say category, but there's really only one, which is memantine or Namenda, and that's one that we'll often add on later when things are getting a little bit more advanced. Again, those old anti-hallucination medications can cause problems, can cause more confusion. Some other medicines can too, some over-the-counter cold medicines even. Anti-nausea medications, some of them also work on the dopamine system. They can cause the same problems. And then even some older Parkinson's medications, things like Artane or trihexyphenidyl, can cause more confusion in people who are already prone to it. Like I said, with the mood things, there's also a lot we can do other than medications. Keeping a consistent routine is very helpful. People with memory problems can still learn much of the time. It just takes a lot more repetition and a lot more consistency to do it. Evaluating for triggers, looking for things that are particularly confusing, particularly bothersome, and trying to reduce those as much as possible. And keeping busy with exercise or social activities, ways to keep active despite limitations are, again, important for Parkinson's in general, but especially for memory problems. Other types of therapy, whether it's formal therapy with a therapist or group classes, music therapy, exercise, adult day services where people can go for a day, give their care partners a break, but also have some fun, is very helpful. And then music is huge. Music, for a lot of people, even who don't have memory problems, hearing a song from 20 years ago can kind of take you back to those times. Music can do the same thing for people who have memory problems. And so just in summary, with mental health, with cognitive problems, we attack these kinds of issues from multiple directions, medications and non-medications. But the biggest things is knowing what they are, knowing that these are a symptom of Parkinson's. They are not a character flaw. They are not something to be ashamed of or to keep to yourself. It's something to bring up, to talk with your doctor about, because if we know it's a problem, we can help, but we can't help if we don't know it's a problem. And so with that, thank you. It's been a pleasure being here, and I hope you enjoy the rest of the day.